Good evening and welcome to Doctors on Call. Tonight we're talking about the diagnosis of strokes and other neurological problems. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host tonight. We'll be taking your calls about everything from MS to chronic headaches to strokes. Just give us a call at 218-788-2844 or toll free at 1-877-307-8762. And here to answer your questions are tonight's panelists. Dr. Dimitri Wanakidis, a neurologist with Essentia Health Duluth Clinic. Dr. Samuel Laney, a physical medicine and rehabilitation specialist with St. Luke's Physical Medicine and Rehabilitation in Duluth. And Dr. Jake Fernuski, a family physician with the Lake Superior Community Health Center in Superior and faculty member in the Department of Family Medicine and Community Health at the Medical School Duluth. Our medical students answering phones tonight are Whitney Bertram from Belgrade, Minnesota, Elise Carlson of Alexandria, Minnesota, and Josh Pritchett from Cloquet. And now on to tonight's program on stroke and other neurological problems. Dr. Wanakidis, I think we'll start with you, and we'll start talking about stroke and then see where we progress. So perhaps you could tell us some symptoms of stroke, what a patient would present like.
The stroke is a disease with many phases, essentially. So it can present in many different ways, from loss of strength to loss of vision, loss of the ability to speak, loss of balance. Even sometimes personality changes can be attributed to a stroke. So it's very broad. So anything we do, any function we have, anything we are essentially, can be affected by a stroke.
Dr. Pernuski, tell us about risk factors for stroke.
Mm-hmm. Well, many of the risk factors for stroke have to do with how we live our lives. There are some risk factors we can't change. Our risk for stroke increases as we age. There are lots of things, however, that we do have control over. For example, whether we smoke, which may be one of the biggest risk factors for strokes, whether we have high blood pressure or diabetes and how well controlled those conditions are. Some people are at extra risk because of an irregular heartbeat or underlying increased likelihood of developing blood clots, which can break loose and cause stroke as well. I think that if I think about stroke prevention, the best thing people can do is lead healthy lives. Eat fruits and vegetables, stay physically fit, exercise, and if people do have chronic health conditions, make sure that they're doing a good job taking care of those conditions and meeting those goals.
Well, Dr. Laney, you're a rehabilitation specialist, and oftentimes people who have strokes, we need additional support and help. Can you tell us what steps you would do for someone who just started in the progress of having a stroke to help them improve their function?
Well, in general, people who have had a significant new stroke qualify for a level of care called acute rehabilitation, which is sort of a special type of hospital. Sometimes it's a hospital within a bigger hospital. When people with a stroke are admitted to an acute rehab unit, like the one where I work, they're evaluated by the physician and the rehab team, which includes physical, occupational, and speech therapists, and even a rehab psychologist. We try to understand the particular deficits of each patient and also that patient's strengths, and formulate a plan for improving function. My role within that would include also trying to help the patient feel well enough to do the rehab, to do the therapy, which of course can be challenging for them, and also to, in some cases, augment their progress through, say, psychoactive medications. I would emphasize that it's a team approach, looking at the patient from many angles. And the hope is that by giving that patient a good start and avoiding some of the pitfalls that could make the patient sick or less healthy or more in danger later, that patient will have better function and a better quality of life, and also to cost less in terms of healthcare dollars later down the road.
Well, Dr. Wanakidis, talk to us a little bit about TIAs. We're getting questions already about the difference between a stroke and a TIA, or is there a difference?
I believe people should see TIA and a stroke as essentially the same thing. So a TIA is not anything else other than a stroke that just lasts less than 24 hours. That's a strict definition of a TIA based on time. So what happens during a TIA in your brain is the same thing that happens in your brain during an ischemic stroke, which is a stroke that is caused by a blood clot. So those who have it we can say they are lucky that our body was able to dissolve the clot, so the blood flow was restored in the brain quickly enough so they do not have any deficits left from this. What people need to be very serious with is that the TIA essentially is a warning sign of a stroke. So that's how they should see it, and they need to take it seriously. Whenever they have symptoms that just go away, they don't need to. They need to talk to their doctor first, and then their doctor they will guide them accordingly.
Are they hospitalized with a stroke or with a TIA? Would you not go into the hospital, or would you just go to the emergency room, or what would happen with that?
We would prefer the patients to visit the emergency room whenever they have any acute loss of any neurological function, whether or not that goes away. And then we decide what the appropriate management should be. So we try to categorize patients based on their risk factors. So people who have a lot of risk factors, it would be better to stay and work them up for stroke in the hospital. People who belong to the less at-risk categories, then we can work out different ways actually of doing the appropriate workup in a timely manner always.
Yeah, I'd like to follow that. I think it's really important because people are at increased risk for a stroke in the days and weeks and even month after a TIA. So patients that have the TIA, maybe they have weakness or trouble speaking, it gets better. So they think, oh, I don't need to worry about it, it got better. When in reality, as you said, that's a warning sign. Mm-hmm. And they're at much greater risk for having a stroke in the next couple of days or weeks, which is why that hospitalization is important, because sometimes we can find things that then we can intervene and make a difference and actually prevent a very serious consequence, a serious stroke or even death.
Exactly. We can screen patients when they come to the emergency room based on their particular risk factors or certain things we find with quick workup that we always do, and then see if there is anything that we can act upon immediately, or then we can just modify certain of their risk factors immediately or long term.
So warning signs that someone should look for. Dr. Laney, if for a stroke, what would you have? A headache, dizziness, lightheadedness?
Well, as Dr. Yankides pointed out, strokes can prevent in a number of different ways. You might not be able to see them. The untrained person wouldn't necessarily recognize that there's a change. But the classic things that one shouldn't ignore would be a lateralized change, weakness, asymmetry, where one side of the face droops, or speech is clumsy, or a person seems confused, or is stumbling, one limb not working correctly. It could be just clumsiness. I think you should have a low threshold of suspicion. Strokes are not uncommon, and there's a saying, time is brain. So if there's a suspicion, maybe it's time to get on the phone with a doctor or indeed go to the ER. Even if it's a TIA, you could look at a TIA as maybe a wonderful opportunity to avoid a big stroke. So those sorts of things.
Very helpful. Dr. Perneski, a couple questions about diet. Does high salt increase your risk for a stroke?
High salt directly probably does not increase the risk of stroke, but high salt can, in some people, increase their likelihood of having high blood pressure. And high blood pressure absolutely increases your risk of stroke. So there are guidelines for how much salt we should take in, and Americans in general get plenty of salt. In fact, in some cases, too much salt. So I think someone who wants to lower their stroke risk should look at those guidelines and make sure they're not eating too much salt during the day. I think most of the salt we take actually is not people adding salt to their food, but it comes in pre-packaged or pre-processed foods that require very little preparation before we eat them. And so people can be aware of that.
Well, Dr. Wanakidis, a caller from Iron River, asking if once you've had a stroke, how often should you follow up with neurology, family physician, internist?
I think that depends on on each particular case, based on somebody's risk factors and what's the possibility of having another stroke. If there are any things in specific that we need to follow up, certain tests that we want to see after somebody had a stroke. For example, if we want to repeat an MRI, if we want to do an ultrasound to check the vessels, if we know that there is disease in the vessels. So it always depends on the case. What we encourage our patients to do is to keep a regular follow-up with their primary doctors, because they are the ones who essentially take care of the main risk factors for stroke, which is diabetes, hypertension, high cholesterol, atrial fibrillation. So these are things that people need to focus on and work on with their doctors.
So Dr. Laney, caller asking about if you've had a stroke and have a paralysis on one side, like what are the odds of improvement that you can retain or regain some of that function on the side that was affected?
Well, one thing I've learned is that you can't make guarantees to individual patients, but you can speak in terms of what physicians and therapists have seen over the years with, of course, millions of people who have had strokes. We speak on rehab a lot about a 3-month window and then a 1-year time frame. The general feeling is that if, say, an arm is paralyzed, if it shows no improvement for 3 months, then statistically it's unlikely that it will show a lot of improvement, that it will become functional. There may be some movement in it, but it's nice to see improvement in this early 3-month window. Then this may come up later, but that's because of something we call neuroplasticity, which is, as it sounds, the ability of the nervous system to change a bit in response to an injury. This neuroplastic process, wherein people can improve an arm that wasn't working, does work to one degree or another. This goes on for a year. I sometimes tell people, if you're asking after a stroke, what will I get back? It may take you a year to know. So, and some people say that neuroplastic window is a 1.5 years. If you're talking about frank paresis, where the limb literally doesn't work, that's one thing. If you have some movement, then you can also work on what we call compensatory techniques or compensation. The difference would be if a fellow has an arm that is flaccid and paralyzed, and another fellow has a similar stroke, a year later perhaps one will say, I can move this arm now. Well, that's neuroplasticity. The other fellow may say, I can't move my arm, but I can button my shirt with one hand, I can tie my shoes with one hand. Both have improved in terms of function and ability to care for themselves. The first fellow did it through neuroplasticity, the second through compensatory techniques. Beyond that, there can be issues like spasticity. In the arm, spasticity tends to move it into a flexed pattern. In the legs, generally, that's an extensor pattern. Well, that tightness, that spasticity may interfere with things like dressing or hygiene, and sometimes medications or even orthopedic surgeries in some cases can allow more flexibility in that limb. Even if the limb's not doing everything it could, it may be a big help in the patient's quality of life and independence to do something with that quote-unquote paralyzed side. For that reason, that question about what to do after a stroke, sometimes it's not a bad idea at all to see a neurologist or a rehab physician or a primary care physician who's taken an interest in those things to ask, is this person, say 2 years after a stroke, can their function be improved?
Thank you. That was really helpful. Dr. Pranuski, asking about aspirin use, is there any role for aspirin use with strokes?
Well, there's a couple different ways to think of that. So one is actually before a person ever has a stroke and perhaps maybe even to prevent a stroke. And so in women in particular, aspirin can be helpful for women of a certain age to reduce their risk of stroke. This is probably true in men as well, but the data is not as solid right now, or you can't stand on it with as much certainty. And after a stroke, there may be some benefit in some patients to reduce the likelihood of recurrence. And so I think most people, assuming they don't have reasons not to be taking aspirin, like perhaps bleeding in the stomach or interactions with other medications they might be taking, benefit from having an aspirin for what we call secondary prevention, or sort of once someone's had a stroke, taking aspirin may help prevent a recurrence.
Well, Dr. Wanakadis, a caller from Duluth asking about headaches. So we're going to switch topics a little bit because now there are some other neurological questions coming in. A headache that lasts longer than an hour, or duration of time for a headache, does that have any significance in strokes or other things that could be happening?
If a person has a headache for the first time and it is that severe, then I think that needs medical attention. So we typically say that it's for the headache, you really need to worry when it is your first, your worst, or neurologically cursed, meaning when you really have a neurological deficit from that headache. So along with the headache, you lose vision, or you lose function such as strength, or ability to speak. So these things that need to alarm people. Without that meaning that this can always be something different. So there are headaches that we call headaches with aura, where you have neurological findings. The reason they need to be seen in a hospital or by their doctor is that this may actually mean a stroke. So these are the things that somebody needs to make sure that they don't have when something like this happens.
Well, Dr. Pranuski, a caller from Superior asking about cluster headaches. Difference between a cluster headache and a migraine, if that's okay.
Yeah, the easiest way to distinguish, or to tell the difference between a cluster headache and a migraine headache from a patient standpoint is looking at the pattern of the headache over time. So migraine headaches may occur once or twice a week to once or twice a month, or even less frequently in some patients, but they'll occur on some sort of regular, not quite predictable, but kind of regular pattern over time. Whereas cluster headaches will simply not happen for months at a time, maybe years at a time, and then the patient will have a series of headaches, multiple headaches a day to daily headaches for several days to a month or so, and then the headaches will go away, and they will go a long period of time again without having headaches. So the name cluster headache actually talks about how the headache occurs when you look at it over time.
Any treatment options for the difference between the two?
Absolutely. So some patients with cluster headaches respond really well to oxygen. You can actually give them oxygen by a little cannula in the nose or a mask, and they'll get better. There are some folks who are using just regular pain medicines, Tylenol and ibuprofen, as well as sometimes the migraine-specific medications for cluster headache, although they tend to be a little bit less effective than they do when you actually use them for migraines. Migraines are actually a very specific type of headache, and there are medications developed specifically for migraine that will work for migraine headache but won't work for all the other types of headaches that we get, like tension headaches, which are very common. And in people who have migraines, appropriately treating them with these types of medications can be very, very effective.
Well, thank you. Dr. Laney, a caller from Moose Lake. So this is maybe a little bit more towards occupational medicine, but asking about stuttering and speech and changes in speech pattern. Any neurological things we would worry about? Would we worry about stroke, or would we think of other things that might be causing that?
I think it's reasonable to be concerned about stroke. If the stuttering has not been lifelong, if it's a new development, I think it's definitely of interest. There are a couple of parts of the brain that could cause changes in speech. And two terms that we use in neurology and in medicine, aphasia and dysarthria. Aphasia refers more to abilities with language. A person, when this caller says stuttering, it's a little unclear exactly what he means, but a person might have word-finding difficulties or groping speech, it's sometimes called. If that's a new finding, that is definitely of interest for a stroke. Or a person might have dysarthria, which is more a mechanical difficulty in speaking clearly, also of interest. Sometimes cerebellar strokes can actually cause a change in the rhythm of speech so that people don't have normal intonation or speech rhythm. So there might be other more benign causes, such as being nervous, but if it's an abrupt onset, then I would suggest it's of interest.
Get some evaluation,
Yeah.
get it checked out. Dr. Wanakidis, a caller from Duluth. Now this is a bigger topic and we only have a few minutes here, but asking about MS and how we diagnose MS.
Multiple sclerosis is predominantly a disease of young people. We say mostly women, but women and men can be affected. So typically it's diagnosed in your 20s or in their 30s when people suddenly experience a change in neurological function. Essentially, they may have deficits that may mimic a stroke. They may be exactly the same in the way they present. So there are a few things that guide us towards one diagnosis or the other. Of course, imaging is very helpful. So doing an MRI and having a picture which is consistent with a multiple sclerosis or a picture that is specific for stroke. Usually the age group is very helpful. You do not expect to see MS in a 70-year-old person, but when a 20-year-old woman comes into the emergency room with a loss of vision out of the one eye, that's a very suspicious sign, and that's the most typical way of presentation for that disease. Loss of vision in one eye or double vision, and I think people need to be aware of that and act fast on it as well, because there are treatments for MS for the acute phase and long term as well.
That's very helpful. Dr. Pernuski, let's talk a little bit about stress and strokes. Can stress cause strokes?
You know, I'm not sure anyone really understands all of the impact stress has on our body. It affects our hormones, our heart rate, our breathing, and many other things. It's a very, very complex process. I think to the extent that stress can increase our blood pressure, increase our control of other chronic conditions, it may relate to stroke. I don't think stress directly is going to cause a stroke, but it may make other conditions worse and make stroke more likely.
What about smoking, Dr. Delaney? Any conversations or discussion about smoking in the next couple minutes related to increased risk for strokes or hypertension?
Yeah, it's not good for your blood vessels. And one way to talk about avoiding strokes is to try to keep healthy blood vessels. It's not good. It increases your heart rate. It's in this day and age, it's hard to know where to start an anti-smoking lecture. But it's certainly a risk factor for many reasons.
It's probably the single most important thing anyone can do to reduce their risk of stroke. If you smoke, quit, or find help in doing so. Because I think of all the things we talk about, healthy diet and exercise and managing all your chronic conditions, quitting smoking, it may be more powerful than any of them.
Yeah, Dr.
I absolutely agree that smoking, especially in combination with other risk factors, because usually they go together, is a significant one, and it's one of the modifiable risk factors. So people can quit and automatically they decrease their stroke risk long term.
So probably one of the most important take-home is if you have symptoms, they're worrisome, you should have it checked out, go to the emergency room or your physician.
The main problem with stroke is that it does not hurt, which is what happens with the heart attack, for example. So people ignore it, they wait to sleep it off, or they wait that to go away at some point, and then may arrive to the emergency room and that is too late. So we encourage people to come to the emergency room whenever they see a change of their normal self, whatever that is, and just leave it on us and we'll find out.
Thank you very much. I want to thank our panelists, Dr. Dimitri Guanakidis, Dr. Samuel Laney, and Dr. Jake Pranuski, and our medical students, Whitney Bertram, Elise Carlson, and Josh Pritchett. There will not be a program the next 2 weeks due to the holidays. Please join Dr. Ray Christensen on January 8th for a program on diabetes, when his panelists will be Dr. Gail Baldwin, Dr. Bruce Henson, and Dr. Dave Hutchinson. Thank you for watching. Good night.